Welcome, I'm Dr. Otten with Cellaxys, and this is my partner.
Hi, I'm Dr. Priya Mohajer.
And at Cellaxys, what we do here is we focus on regenerative orthopedics and spine medicine.
I'm the Director of Spine and Interventional Medicine, and Dr. Otten does mostly the extremities.
So I'm the Director of Orthopedic Orthobiologics, or regenerative orthopedics in this practice. And we've been practicing this now for about 10 years with regards to regenerative medicine, and both in the spine and the orthopedic extremities. So while we're waiting for people to kind of join us here, I'll give you a quick background of who we are, what we do here at Cellaxys. So at Cellaxys, what our focus is, our main focus is improving your pain or injuries, whether it be from chronic arthritic pain or arthritis, to acute injuries or to subacute injuries, and healing those injuries naturally. Another big thing that we try to do is prevent surgical interventions with significant improvement in pain. And the way that we do that is taking something from your body that has healing components, concentrating that, and re-injecting it specifically in the location of the affected or injured tissue, whether it be from arthritis, a torn ligament, a torn capsule, or in spine.
So we can actually utilize the problems you have in your neck, the mid-back, and the low back, in addition to having symptoms down the arms or down the legs. So pretty much any area that you have pain, we like to see the patient and make a recommendation.
You know, and what we've focused on here too over the last few years is harvesting what we call something either mesenchymal stem cells, PRP, or something called A2M. But our goal here between the two of us is to really focus on your injury and healing it naturally.
Absolutely. So the more information we have about the patient, the easier it is for us to make some recommendations.
Correct. So always imaging is important, don't you think?
100%.
Whether it be an MRI or an X-ray. So
yeah, we wouldn't do anything without any imaging. So we pretty much require everyone to have some sort of an imaging so we actually know what the problem is. And in addition to the imaging, the physical examination is very important. Without actually touching the patient, you're not going to know where the actual pain is and what's causing the pain.
Correct. Correct. So let's do this. Why don't you give us a brief background of your background, where your training was, what you do for fun, and I'll do the same, and then we'll begin.
So I've actually been involved in pain medicine for approximately 20 years. I started in Las Vegas in 2004 after I finished my fellowship in Boston. And throughout my fellowship, I actually noticed that there was a lot of usage of opiates. And I was always against opiates for non-cancer patients. And unfortunately, we didn't have a lot of options for the patients. We did some sort of injections and other modalities that
these would be cortisone injections, correct?
Cortisone injections. We did like radiofrequency. Obviously, we had spinal cord stimulation. We had intrathecal pumps. But everything was sort of, I don't want to say just completely masking a symptom, but we were treating the symptom, not the root cause of the problem.
Correct. You just kept putting things on top of it to reduce the pain, but it'd come right back.
And the whole idea was to improve the quality of life. I mean, I think it's difficult to completely get rid of the pain. So as my training went along, and I started looking for alternative stuff that included acupuncture, inversion tables, or other types of physical therapy and other modalities. And it was not till several years ago that we started having discussions that we decided to talk about regenerative medicine. And that was sort of an eye-opening for me. I did not have a lot of information on it. I'd heard about it, like a lot of the athletes that were using some of these, especially platelet-rich plasma, and they were going to Europe, mostly Germany, to get some of this stuff done. So I really delved into it, and the last few years we've been working very closely with each other and trying to figure out what's the best modality and treatment for these types of patients.
So you're really focusing on regenerating tissue in the spine for long-term improvements, not just the quick cortisone, cover up the pain, it's back in 6 months. You're looking for years of significant improvement in your cases.
Correct. So obviously any type of therapy has side effects, especially with steroids. And the steroids, the problem is like over long-term usage, you're going to have a lot of side effects, and they can only do so much. I mean, the steroids are anti-inflammatory, so they're going to decrease the inflammation. And unfortunately, after a while, when there's a lot of chronicity, like the problem has been around for a very long time, there's only so much these steroids can do.
Correct.
So we're looking for alternative ways to help with the healing process, and in addition to that, introducing something that can help with the regeneration of some of the tissue in the specific area that we're actually putting the cells.
Correct. So the same thing in my situation and within my field too. I'm sports medicine fellowship trained at Beaumont Hospital in Detroit, Michigan, and we obviously have professional teams in Michigan. Whether they're good or bad, I won't comment, but I still love them. But these athletes, the professional athletes, about 10 years ago during my fellowship, were really looking for alternatives, because what we did was opioids and cortisone injections. And athletes became aware of the fact that cortisone really degrades joints. It's actually something called chondrolytic in orthopedics. And chondrolytic means it kills the cartilage cells. And the cartilage cells is what makes the joints glide pain-free, and so these guys can maintain their careers. And the same thing with facet joints in the spine too. These are articular joints as well. So professional athletes really kind of got me into this field 10 years ago. And that's what spurred my interest with this, is looking for alternatives that got players back on the field. Now 10 years ago, this was only, for the super elite and for the ultra athletes. But over the last 10 years, the popularity has absolutely exploded. And now it's for everyday people. So it's for you, it's for me, it's for my mom, it's for your parents as well.
Correct.
And so it's really expanded. And so what's important about that is picking the right people that have enough experience, that know what they're doing.
And to go on that as well, is like, also you have to know the level of injury or the problem that the patients are having. So it's very important to have a consultation with the physician that's done this before and knows what to do. Just because it's out there doesn't mean it's for every patient. So that's very important at Cellaxys, because we do emphasize the patient as a whole and not just looking at one specific area. So when you do come in here, we do a full, thorough physical examination. We look at all your records. For me, at least in the spine, I'm very interested in what sort of procedures they've done in the past and if it's worked or not, because quite often, if you do the steroid injections, that could be a very good quote-unquote diagnostic tool, like a test.
Absolutely.
To see if they actually did well at that level where they had the injection. Then they'd probably be a very good candidate for some of the therapies that we're offering.
Correct. Now, just on a personal level, before we begin, since I see more and more people are joining us now, what do you do for fun?
So when I'm not in the office, which is rare, but I love to go snowboarding, and being in Nevada, I think the closest place for us, the easiest way is like Mammoth. So I always like to go there. And once a year, I try to go on a backpacking trip. So with some of my friends.
These years, I'll make it with you, I promise.
When the knee's better.
When the knee's better. So actually, that kind of gets to a good point too. So my personal hobbies, and I like being outside. Dr. Mohajer and I are very similar in that sense. We both, if we're not working, we're outside and being active. So I've done one of these procedures, and I'll get to that in just a second. But my big hobbies are skiing, surfing, rock climbing. And I used to play rugby for University of Oregon too. I'm married and have a young 4-year-old daughter, and as you know very well, she pretty much absorbs all of my time at this point. But that being said, I had ACL surgery, and I'll give you a quick caveat before we begin. I had ACL surgery about 1.5 years ago, and I just wasn't recovering the way that I wanted to recover. I wasn't able to run yet. I tried skiing once, it kind of failed. I pulled back on it, but I was still having that chronic intermittent pain where I just couldn't quite get to that extra edge where I felt good and felt confident. And this is about 1 year, 1.5 years out now. So 7 weeks ago today, I think 6 or 7 weeks ago today, you actually did my procedure. And after the third or fourth week, I felt significant improvement. So one thing that I really have noticed that I can tell patients now is my sleep is better. So I'm sleeping much better at this point in time. I don't have that chronic night pain where I turn over and it kind of catches or it's achy. I wake up in the morning not stiff, and for the first time in about 1 year, I was able to play chase with my daughter, which really made me happy. So I've continued to improve. So on that note, we have enough people now that have joined us. The vast majority of patients have joined us in this conference. Why don't we begin our discussion?
Sure. Before we get going, actually, I want to thank everyone for taking their time to participate in this webinar. I know everyone's time is valuable, so we actually have an offer for the participants in this webinar that we will be offering a free initial consultation. And for those patients that are out of state, we will be offering a televisit as well. And we will get into more details at the end.
Yeah, we'll discuss that at the very end. Thank you for your time.
So at this point,
so let's talk about so let's actually begin the discussion, and let's talk about what our agenda is today. I will be looking down occasionally to see what questions are being asked specifically from the people that are listening to us out there right now. So what is regenerative medicine? So regenerative medicine basically is a solution to pain and injuries and chronic pain and arthritis. And it's taking something from your body that has healing components, concentrating it, and putting it back into the area of injury to heal your pain and injuries naturally. That's the basis of regenerative medicine. And regenerative medicine started realistically for orthopedic and spine about 20 to 25 years ago, initially in Europe, and then slowly came over to the United States. In the last 15 years has really begun to take hold in the United States.
And in the spine aspect of it, actually, the last several years there's been an explosion of research and clinical studies that are very exciting, and new data is coming out every week, and it's actually showing a very positive response that the patients are having to these therapies.
And I think it's important to say too, regenerative medicine actually, when this first began 10 years ago, I'd have to talk about it all the time and explain it to patients, and it kind of sounded like voodoo medicine. But in the last 3 to 5 years, there's been this explosion, just like you said, and patients are now seeking this out. Like, this is now a commonplace therapy and medical treatment for patients. So they're really beginning to seek this out. So it's very important to get good, solid education on this from people who have done it for a long time.
Absolutely. And unfortunately, patients have been through the gamut. They've had injections, they've had cortisone, and they've been surgeries that have been unsuccessful, or they're contemplating surgery and they're very wary about it, which I would be too. I mean, I would never want to have surgery unless it was absolutely necessary, because being an anesthesiologist, I've seen it all. So the less I do to myself, the better off. But I think that's probably true for most physicians, because they've been exposed to what's out there, and they would rather do the least amount that's possible in the surgical aspect, and try to use every other modality that's out there before going under the knife.
Oh, I absolutely agree. Had I not had to do it myself personally, I wouldn't have done it. So realistically, regenerative medicine actually began in the 1950s when we began doing bone marrow grafts.
Correct.
And since then, there's been more and more data. In about the 1990s, we really started seeing spine and orthopedics get into this realm. In 2017, actually 2017, the federal government, the FDA, started putting very, very strict guidelines for this because it became so popular, and they want to rein this in so it's safe and effective for patients to have these procedures performed.
100%. So the guidelines are very important, and we got to make sure that there's a lot of clinics out there that are promising things, and patients are smart enough to do their homework. And I think it's very important to do your research and make sure it's the appropriate clinic for you and the appropriate information, and look at what they're promising. And you gotta,
that's important.
Gotta be very careful. There's a lot of people out there saying things that are probably not in the best interest of everyone.
I keep hearing the same thing over and over. You know, patients will come to me and say, can you guarantee this result? I heard it's going to be 100% effective or 98% effective. And within, honestly, that is not a number that I state and quote to patients. Depending upon the injury, it can range from 80 to 92% success rate, but it depends on the injury, and it's very specific. That is not a global blanket statement that we're going to have pain-free patients. That is not true. But we are if you're the right candidate, we are significantly going to improve your pain and your function, your quality of life.
Also, again, it depends exactly on what type of problem you have, how severe the degeneration is, and what was the cause. Again, so this all goes back to seeing the patient, looking at your images, and giving you an honest recommendation.
Correct, a quality consultation. So stem cells is the latest thing that we're now starting to use. We started to use it about 6 or 7, maybe 8 years ago in the US on a regular basis within spinal and orthopedic medicine. And we're deriving stem cells from 3 major locations, 2 of which come from you. Those 2 are either your bone marrow or your adipose tissue. The third option is a third-party option coming from a company that concentrates something from birth products, whether it be placental tissue or cord blood tissue, and they're concentrating those, freezing them, and sending them to the clinics. In my personal experience over the last 10 years and yours as well, we tend to focus on autologous, meaning coming from you. So either from the bone marrow, the blood, or the adipose tissue. It's safe, it's controlled, and we have full control over the environment. And to date, I've never had a complication in doing this for 10 years because we regulate it and it's all done in-house.
And to continue with that, and I agree with for the spine, the bone marrow, I think it's probably the best source of these types of cells. Most of the studies have been done on the bone marrow, so all the research that I've followed through and the results that they've had, it's been very positive. I guess we could delve into some research at this point.
Well, tell you what, before we do that, for patients that are listening in right now, why don't you discuss briefly some of the major things that you treat within the spine?
Sure. So dealing with the spine, so I deal with, we could go by the parts. So let's start with the neck. So any neck pain, any type of headaches that start from the back of the neck. So these are usually due to a facet problem, and facets are these joints in your spine that allow the spine to go forward, backward, and side to side. People get into motor vehicle accidents, they have the whiplash. So these are the candidates for the problems that arise from the cervical spine. People do have some pain down the arm, which could be due to a bulging disc.
So you're talking about the pain all the way down into the fingers.
Correct. So they could have the numbness, tingling, or some weakness as well. So those are some patients that we'd have to look at the MRI and see if they're a good candidate. In the mid-back, you still have the same type of issues with the facet joints. And in the low back, which is probably the biggest area that people have pain with.
And that's also the most treatable area in the low back, right? Like you can do more procedures in the lower spine?
100% true. The discs in the neck and the mid-back are quite small, so we don't actually do anything to those discs. In the lumbar spine, in the low back, the discs are much bigger, and that's where actually we can do some therapies in addition to the facet joints.
So you can actually inject the discs in the lumbar spine.
So that's what we actually end up doing. We look at the MRI and see which is the level that's having the most degeneration. We look at the physical examination of the patient and the symptoms that they're having. If it's purely axial, meaning just the pure back pain, and they have some sensitivity when I touch their back along the sides where the facet joints are, they're probably a good candidate for a intradiscal injection, like actually putting the cells into the disc as well as the facet joints themselves. Now again, as you mentioned earlier, facet joints are just like any other joints in your body. Your knees, hips, and your shoulders, you develop arthritis. Most of the young people have issues with the facet joints secondary to either trauma, horseback riding, gymnastics, and motor vehicle accidents. And just like any other joint, as we age, arthritis develops. And those are the patients that tend to have more problems with the facet joints as they age as well. So again, going back, so the low back pain, in addition to leg pain, depending on if it's due to a bulging disc or just an irritation from a bulging disc that's actually releasing some chemicals and irritating the nerve, those are potential candidates. And again, we have to see the patient to.
So really the gamut's wide open, and the treatment options tend to be wide open for spinal pain. It's just whether or not you can isolate the pain source and if the patient's a good candidate.
100%.
Great. And as far as orthopedic is concerned, it's a little bit wider of a blanket. You can actually, it's a wider net, so to speak, because orthopedics is very similar, and every single joint is very similar. You either have tendons, ligament, cartilage, bone, or joint capsule or synovium. And all of those things, and muscle obviously, And all of those things can be treated with regenerative or orthobiologic therapies. Let me actually define orthobiologics. Orthobiologic is a word that we've used for quite a few years now, and it's the orthobiologics is either stem cells, PRP, A2M, all these various compounds, but orthobiologics is something that comes from you. And now people are now using the word orthobiologics because it's a pretty complicated word, and they're now saying regenerative medicine, orthopedic or spine medicine. So if I do use the word orthobiologic, I'm discussing something that comes from you that has healing properties that I transplant into some other place. So orthopedics, I think the major things that I typically see in orthopedics and regenerative orthopedics is knees are probably by far the most common because everyone has arthritis in the knees and early degradation of cartilage, etc. Hips, shoulders, elbows, wrists, and foot and ankle. Those are my common things. And for me, I will work on virtually anything in any of those extremities.
Absolutely. So the results have been very good. Obviously, you've been doing this for about 10 years, which is probably longer than most people that I've researched on. And do you want to share some of the results?
I will. So actually, before I do that, this actually revolutionized my personal practice. I ran a very busy private practice, sports medicine, saw insurances, did the whole 9 yards, got the MRIs, the x-rays. And over the last 3 to 5 years, I saw a significant increase of patients more interested in regenerative orthopedics than the classic conventional, cortisone shot, let's get an MRI, let's do this, X, Y, and Z, which you alluded to earlier. So this particular subdivision of my practice revolutionized my practice to the point where this is really basically the main focus of my sports medicine practice at this point in time is regenerative orthopedics because of A, the outcomes, and my success rates have been extremely high and I'm very happy with them. B, the minimal downtime that this has for patients, few hours to a few days, and C, the long-term results. So this really revolutionized my practice.
And I think something we've discussed before is that how some of your patients actually come back and they have other joints that they want to do, and they actually do one joint to see how it works, and then it's like, oh my God, this was such a beneficial
game changer.
Yeah, exactly. Yeah. And then they're like, okay, I have all these other joints that I want to test to see if it's going to work or not.
Absolutely. So it really revolutionized my practice. A couple different things what we see, and we need to define pain before this begins. Before we give this lecture, I want to define pain. There's 3 main types of pain. There's acute pain, which means an injury that happened here and now. You tore something, you chipped a piece of cartilage, you have a herniated disc or an annular tear.
You bend over, pick up something, you hear a pop, you're like, ugh. Then you're on the floor.
So that's the acute pain, something here, now, less than 6 weeks on average. Subacute pain is something that happened, but it hasn't quite healed, and it tends to last anywhere from 4 to 8 months. So you got a little bit better from that initial injury, but you're just not getting better. And that's what we define as a subacute. Anything typically probably up to 8 to 12 months, I think, is a safe range for subacute. And then you have the chronic issues. Chronic is anything that's lasting more than a year. The most common problem that we see in orthopedic issues for chronic pain is arthritis. And in spine, the most common problem for chronic issues.
So typically it is the back pain.
So would it be degenerative disc disease or facet arthritis?
So it says it's a combination.
Okay.
So when people come in with the back pain, there's a lot of structures that can cause back pain. So it's not one particular area that's causing it. So it could be degeneration of the disc, it could be coming from the facet joints, it could be the injury that initially that was causing the problem, or a combination of the all those areas. So this is why actually in our business, like, injections are important to delineate, to find out where the actual pain generators are coming from.
Correct.
Now I know a lot of people we have had a couple of questions about what what's the time frame for acute and chronic? I know there's been other quotes out there. Some people
Correct.
talk about 6 months.
Correct.
Anything more than 6 months is chronic. So 1 year, again, it's there.
It's there. It's been there for a while.
It's causing a lot of problems. So if someone, because we just had a question, it's like, oh, what about 6 months? So yes,
Correct.
It's out there. So there's a lot of literature out there about what the time frame is. But again, if it's there for a long period of time, we consider it chronic and need something to be done. So the healing process is pretty much completed of your body was trying to do, because obviously as soon as their injury occurs, your body tries to heal itself. And when you go past a certain point, most of that process is completed. So now you're left with some chronic issues, and what do we do about it? So as we mentioned earlier, steroids are not always the answer.
Absolutely not.
So let's see.
So some of the conventional treatments that we've used in westernized medicine to treat this type of pain is either simple cortisone injections like we've talked about, which only last a short amount of time and ultimately are degradative or degrade the joints, tendons, ligaments, etc. But those are degradative. One other complication that you can hear occasionally from multiple cortisone shots is the development of cataracts. We just had a patient yesterday where she couldn't do any more cortisone injections because of her cataracts. Actually, she had actually developed eye issues because of the multitude of cortisone shots that she had reached.
Also, the problem with people with diabetes, obviously the cortisone increases your blood sugar levels, so you have to be very careful with those patients. People that are pre-diabetic, we don't want to push them into the diabetic zone. Also, prolonged use does not provide the relief that people are always looking for either.
Absolutely not.
And then going back to the conventional stuff, so when someone comes in, I mean, I think I'm a very conservative pain management physician, so we want to make sure we use all types of modalities before we go into any more invasive stuff. So that includes physical therapy, acupuncture, inversion table, and most of the patients have already done most of this by the time they come to us. Things have changed over the past 10 years. Like, patients have pretty much been on every type of medication, every type of modality before they come to us. And the primary care doctors have gotten much better about treating some of these issues. So by the time they come to us, it's like, okay, now what are you going to have to offer? It's like something no one else can offer anymore.
Correct. And obviously, a couple of the other things in the traditional stuff is you kind of go through the paradigm of, NSAIDs or anti-inflammatories, ibuprofen, Aleve. Those get extracted through the kidneys, and so long-term utilization of those medications can harm or damage the kidneys, so we really try and stay away from those. Therapy, physical therapy, all the other random modalities out there, and ultimately potentially surgery too. In a lot of cases, about 80% of the injuries in sports medicine that come in, 80% of those injuries are non-operative. So there's a gap of about 80% of patients that are looking for something different, something new, and something that actually has long-term relief for their pain. And it's virtually the same in spine medicine too.
Yeah, it's true. And also one big aspect that we've not discussed is the opioids.
Absolutely.
And that's been a hot topic for the past, I think, 20 years. And the pendulum seems to have swung the other way now. It's like there's a very restriction on how people are prescribing it and what they're prescribing it for. Obviously, being in pain medicine, we do deal with a lot of people on high-dose opiates, and I've always been in the school of thought that the less is better. There's so many side effects from these medications, and unfortunately, the number of people that are dying every day has become quite a bit of an epidemic.
Absolutely.
Obviously, a lot of that has to do with the illicit medications or the illicit fentanyls that people are dying from, but there's still about 50% of those are prescription medication deaths.
Absolutely.
So again, to be able to cut down on the opiates or your other medications, provide you with some long-lasting relief, I think that's the key. And in my practice, and I'm sure yours as well, is that we're looking for an improvement in the quality of life. So that's the most important thing. You could have patients report, okay, I feel 50% better on my pain level, but I'm actually walking, I'm sleeping better, I'm doing things that I was not doing before. I can deal with some pain. Again, I think if anyone ever promises you pain-free, I think you should leave their clinic.
I fully agree.
So it's more of a approaching the patient as a whole, that we want to treat you as a patient, including your pain, your sleep problem, and your activities of daily living. So if you can have some improvement in all those, I think patients tend to be very happy and want to move forward.
Correct, I agree.
So we did discuss surgery. So again, I think that would be our last option.
And
there are patients that unfortunately nothing's worked and then they need surgery. And
Absolutely.
That's why the evaluation is very important, especially if anyone has any significant problems, like if they have a bowel or bladder issue with the spine, that's a surgical intervention that's necessary. So let's see what else we got.
So someone made the very good point right there, actually, that the vast majority of Western medicine is utilized to treat just the condition. That's all we're doing. And this person that emailed in is absolutely correct. Basically, Westernized medicine is aimed at fixing the pain and calming the pain down, but not actually healing the pain. And that's what regenerative orthopedic and spinal medicine is aimed at. And that's our focus, is fixing and improving the actual pain source, not just putting some water on that fire and then the sparks come right back up 6 months later.
Yeah,
so that's a very good point.
Actually, that's a great point too. It's like we're such a society, it's high paced, everyone has to work, everyone has to do this. I have back pain and you just like, I don't have any times to have downtime.
Throw some steroids.
Yeah, no, let's gotta do something. Let's get back to work and let's move forward. One good point about this gentleman is about having an operation after the initial one. So surgery could be a very slippery slope. You have one operation, then you might have to have another one and another one. At least in spine, when you do have the fusion, which is basically you're fusing your back and you're preventing that level from moving. So they typically either go, at least in the lumbar, they can go through the front and the back or just the back. And once you're fused, that level becomes, the level above and below become the pivot points. So the level you're fused, you're not moving anymore.
Yeah, it's the levels above and below where the fusion is that now change in biomechanics.
Correct. And then most studies show that within 10 years, you could have up to 30% of the patients have changed at those levels that might need further intervention.
And I think that drives the point home why more and more patients are looking towards your regenerative medicine procedures to be in the spine to alleviate that potential necessity for one surgery, which leads to another one, which leads to another one, and it tends to be a downward cascade.
Correct. And unfortunately, it's difficult for the patients as well. It's like, okay, I had one surgery, maybe the next one is going to help, or maybe the third one's going to help. But I've seen the trend, I'm sure you have too, is like over the past 10 years, they're trying to cut down on some of these fusions. I mean, back in the day, I used to see 5-level fusions in the back, and I'm like, oh my God, this is like...
Spine surgeons are now becoming much more conservative.
Yep,
So.
I agree. And the outcomes hopefully are better too, and let the body heal itself and look at all their alternatives too.
Absolutely.
So so they were asking about the medication that we discussed already.
Correct. So basically, let's start the lecture on this, and we're going to talk about, and we'll interrupt each other if we think that there's good points that we can kind of focus on. But stem cells and regenerative medicine in general really began in the 1950s, like we discussed, with bone marrow transplantations. Since then, about the 1990s, regenerative medicine started to take hold in both orthopedic and spine medicine. And in 2016, believe it or not, workman's compensation insurance began to cover bone marrow concentrate for certain injuries. Workman's compensation insurance is a business model. So they need to keep their costs down with improving the patient's outcomes. And in 2016, they realized, there's a subclass of patients that don't require surgery, and if we do this alternative, they're going to get better for 1/10 of the cost. And so actually workman's compensation now covers these procedures. Another insurance company that covers these are professional athletes. So professional athletes are covered for these procedures because those insurance policies see the benefit in it with regards to minimal downtime, good solid outcomes, improvement in pain, and then their players are back out in the fields a few weeks later. And in 2017, like I mentioned earlier, the FDA came down, November 2017, the FDA came out with very strict guidelines of what you can do, how you can do it, and they did that for the safety of the patients. And
Sure.
everyone's heard of the rogue clinics and the blindness complications, et cetera, et cetera. So the FDA is really beginning to regulate this on a basis to ensure the safety for patients.
Which is great. We need that.
Oh, we need that.
Yeah.
We need that.
So we want this regenerative medicine to continue and improve. So we try to get some of the other clinics that are not promising things that are not accurate to change. Hopefully.
I agree.
So there was a little bit of a time that Medicare was covering the platelet-rich plasma, the PRP, and that was a short window. But obviously they needed some more data, and that's coming. So there's again, as we talked about, how much clinical trials are ongoing. It's a significant number. I think the last time we looked, it was like over 700 at clinicaltrials.gov, and it's very exciting.
Yeah,
so
700 clinical trials. So there is going to be some amazing data coming out in the next few years. And I think, honestly, the dominoes are beginning to fall. More and more insurances are starting to pick up on this and recognize the benefits of it and the cost savings of it. So I think in our lifetimes, at some point in time, in the next 5 to 10 years, I think we're going to see this as a classic conventional option that is covered by insurance at some point. I'm keeping my fingers crossed.
yeah, I think as soon as these studies come out and there's some standardization of the process of what are you actually putting in, how much are you putting in, what's the approach, and there's some guidelines that are actually provided, I think we'll see a lot more consistent benefits that we've been seeing the last couple of years.
Absolutely. So instead of talking about PRP and some other modalities like alpha-2 maculoglobulin or A2M or some other stuff like that, I think exosomes. So I think the big push that everyone's really interested in now is the stem cell therapies. And so today we're going to focus on that talk specifically, the stem cell therapies. We can obviously, if there's a question that pops in at the end, we can obviously discuss some other modalities, but today's lecture is really going to focus on stem cells. And so what are stem cells? So stem cells are the building blocks of the human body. We started out as actually 2 cells and obviously differentiated into multiple cells. But in orthopedic and spinal medicine, we're looking for a specific stem cell called a mesenchymal stem cell. And these cells will multiply, self-multiply. They divide and self-multiply and make replicas of themselves. And then they can differentiate into various tissues, whether it be cartilage, bone, tissue, blood. So in our field, we are specifically looking for a mesenchymal stem cell. And these are a pluripotent cell. You'll hear that keyword, pluripotent cell, meaning they have a lineage, or they start here, and they can become multiple different tissues in the body. So they're pluripotent, not omnipotent, which is a word you may use or hear at some point in time. And these cells can specifically come from either fat or bone marrow, and they can differentiate after they multiply. Adipose tissue on average will multiply about 8 times. Bone marrow will multiply about 5 times, and after that multiplication process that they go through, then they become the cells that you're looking for, whether it be a skeletal muscle cell, a tenocyte or a tendon cell, something called a chondrocyte, which is what we're really interested in half the time. Sure. Chondrocytes are cartilage cells. They can also become bone cells, fat cells, and a couple other. But within orthopedics, we're really looking for a couple specific things that they differentiate into.
Correct. And also, especially where we put it.
Correct.
So that's what's going to make some changes in the lineage of the cells themselves.
Absolutely. So they're a really interesting thing, and here's where I'm going to defer to the slide because you really need a visual on this particular situation. But stem cells are a really fascinating cell. I always describe them as an octopus. It's a pretty good analogy for them. But basically they're these little cells that swim around and look for injuries because injured tissues gives off a chemical signal to latch onto. So these stem cells look for these chemical signals of injured tissue, and they latch on basically. And on top of them, so if you look at the pictures here on the screen, on the top of them, they create this invisible force field so cells don't attack them and kill them, so that these cells, the stem cells, can stay alive and viable and regenerate tissue underneath those tentacles for about 12 to 18 months. And we've radio tagged these cells in clinical studies where we've put little radioactive material that emits an energy that we can pick up so we can see if they're still alive. And so we've radio tagged these cells and they live for about 12 to 18 months and regenerate tissue. So any stem cell procedure and repair tissue. So any procedure that we utilize mesenchymal stem cells for, you're going to regenerate tissue for about 12 to 18 months. So like I said, there's two main locations where we get what we call autologous, your own stem cells. That's either from adipose tissue or bone marrow. In both situations, these cells lie dormant and they're waiting for the signaling, the chemical signaling for the body to mobilize. I basically like to describe them as hibernating bears. And when the springtime hits, or there's an injury and your body sends out these signals that, hey, we need to repair ourselves, when the springtime hits, these little dormant stem cells that have been hibernating mobilize throughout the body and begin to heal tissue. In our practice, we do a little bit something different. We take those little bears out and those little cubs out from hibernation, we concentrate them, and we activate them using platelet-rich plasma therapy, and then we re-inject them. So we're basically taking the bears out of their dens, concentrating them, and placing them back into areas of injury. And just before that, what we'll do is we'll activate them with PRP.
Sure. So I think it's important, just for clarification, that what we're trying to do, or what we're doing actually when you come in, we do take about 50 cc's of your own blood.
Correct.
That we spin that down in the centrifuge, and that becomes your platelet-rich plasma. So that's the activation that Dr. Auden was talking about. And then for the bone marrow, we do take 50 cc's of your own bone marrow from your iliac crest, from your hip bone area, and we spin that down as well, and that becomes the bone marrow aspirate, and we combine the two and then we place it in the area that's the injury occurs.
Correct.
Has occurred.
Please interrupt me if I always do that stuff. I talk about this all day long, so for me, it's just normal.
Make sure everyone understands what we're talking about and everything too. So we could talk a little bit about the procedure itself. I'll talk about bone marrow, and we'll talk about the adipose and stuff.
So great.
The bone marrow, everyone, when they talk about bone marrow, they always get worried about, oh my God, it's going to be painful. They're trying to take it from my hip. So everything is done with sedation here. We do numb up the area so the patient is quite comfortable and it's not that painful. We do use a special needle to get into the bone marrow through your iliac crest. And at that point, when we, as I mentioned,
which
we
is
take
the
about
butt
50,
area.
That's the butt area.
That's the best way to describe it.
Yeah, it's the butt area. And then we take about 50 cc's of the bone marrow out of there. The procedure itself takes about, for the bone marrow aspiration, it's not that, it takes about 10 minutes tops. And then, and once we do the whole process, so I think depending on how many joints we're injecting or which part of the spine we're doing, about an hour procedure to an hour and a half.
Yeah.
That's pretty much it.
Normal.
And then one of the biggest questions people have is about pain afterwards. So again, as far as putting these cells into the disc, it's going to be quite painful for about 3 to 5 days, I would say. And we do give pain medications to offset the pain. And these are much different than steroids. I'm sure a lot of people have had steroid injections. And the steroid injections, you kind of there's some local anesthetic that's actually placed with the steroids, so people get some immediate relief from the steroid injection, and the steroids themselves kick in about 36 to 48 hours, so people start feeling good in a relatively short span of time. Unfortunately, with stem cells, it's completely
it's the opposite.
It's different, so it's going to take some time for the healing process, for the regeneration to occur. So patients have to be patient, and that's...
So for spine, is it safe to say patients are in a relative discomfort, nothing terrible, but a relative discomfort that can be easily treated with medications for anywhere from 4 to 7 days after the procedure?
Correct. And then by 1 week, people are starting to see some changes in the level of their pain. And I think what we always discuss with our patients is that anywhere from 4 weeks to 6 weeks, you start to see some changes. Then about 6 to 8 weeks is when people tend to see the most amount of changes. And when we do these seminars that we have been doing for some period of time, we always quote some studies, which we'll probably go over in this webinar as well, is that most studies have shown anywhere from 50 to 70% improvement in your pain, and that could last anywhere from 1 to 3 years. Most of the studies that have come out so far, the longest one that I've been able to find, they follow the patients for 6 years. That was a little bit different than what we do. They actually cultured those cells. So they had an increased amount of stem cells. That's not what we do because it's not FDA approved.
Correct.
So that's more of a research at a tertiary institution.
Yeah, and those are in research institutions.
Correct. So the other studies have showed, again, 50 to 70% improvement and anywhere from 1 to 2 years, even 3 years in the last study that I saw.
So on the flip side, I do bone marrow concentrate as well for orthopedic problems, but I'll talk about adipose, as adipose tends to be utilized much more in orthopedic medicine than in spinal medicine. Whereas in orthopedics you can do both, but I'll talk about the adipose procedure. So over the course of the last few years, there's been more and more technology and technological developments. What we found here at this particular clinic, there is a special liposuction machine that is specifically made for this to harvest live cells and with minimal destruction. So we use a very special liposuction machine here that's manufactured and produced and engineered in Germany. That being said, the process is a little bit longer than bone marrow because of the liposuction.
Correct.
The process usually takes about 2 hours, I think is a safe bet to say, give or take 15 to 20 minutes on either side, but about 2 hours for the process. So what we'll do in the adipose stem cell therapy and procedure is we'll take you back to the OR, we'll take some blood to make PRP, just as in the other cases of bone marrow concentrate. Once we've done that, we place an IV into your vein, usually the hand or the upper extremity, and we'll inject medications to relax you. What we'll do then is put you in a deep twilight state. So you're kind of awake, kind of not awake. You sleep through about 75% of it, and then you gently wake up. But we'll keep you in this nice plane of a deep twilight sedation.
We have our anesthesiologist available that does this.
Correct. Our anesthesiologist is always available and comes in and scrubs our cases. So there's always an anesthesiologist available and on hand for every procedure. I'm a firm believer of that. It makes my job easier. It makes your job easier. That way we focus on our job and nothing else. Then we do 2 small incisions, less than 1 centimeter, typically on either side of the abdomen. We tend to go for the abdomen. That tends to be the best workable adipose tissue, and we perform.
We all have a beer belly. Huh?
We all do have a little extra. I'm not going to lie. No matter how hard we work. Now, some of the pro athletes are a totally different story. I get those guys. No way. We'll go for bone marrow on those guys. But so we do a mini liposuction, which takes about 45 minutes, and then we have to process the adipose tissue in minimal manipulation style under FDA compliance guidelines.
Correct.
Once we've done that, we combine it with PRP to activate the stem cells. And then we'll typically, after that, we'll use a combination of both ultrasound and live X-ray called fluoroscopy to inject these stem cells in combination with PRP into the locations of injury. And we always confirm it.
But that's a very important point, that everything is done with image guidance. So that means either X-ray or ultrasound, as Dr. Auden mentioned. We don't do anything blind. Like we know exactly where we're putting the needle, and the needle placement is actually confirmed with the contrast, the small amount of contrast to confirm where we're putting the medication, because these procedures are very specific on where you actually put these cells. You just can't just put it in a vein and just say, okay, it's going to go to the injured area. We want to be specific of where we're actually placing these cells.
And I think clinical outcomes reflect that. Like if you shotgun approach this and kind of get it in and around the area, your results are going to be 30-40%. It's probably because of the anti-inflammatory effects.
But it doesn't last.
No, it doesn't last. It's going to be gone in 6 to 12 months.
And then you spend all that money, and then you're going to have to go back.
So we really believe in sniper shots here. Like no shotgun approaches here. I want sniper shots. I want exact shots. And we do that for every single injection in our practice.
Even the joints, we do it. It's like there's like studies, like I've been an anesthesiologist, we do epidurals all the time, and back when I was training, we didn't use any fluoroscopy. In the pain, for the pain fellowship we did, but prior to that we didn't. And there's studies that 30% were not in the right area, you know,
Correct.
and it's just true. And then you're like, okay, I'm in.
Well, if you take the sacroiliac joint, this is a great example. Everyone's going to so the SI joint, sacroiliac joint's in the butt. And if you take this thing, for example, so if you inject that and everyone says, oh, I've done hundreds of these, I'm always in, it's still a 50-50 shot if you go in blind.
If that.
If that.
I would say it's much less, but you need imaging.
Even with the knees, there's been studies done on the knees.
I agree. If I was going to do a procedure like this, I want to make sure it's in the right area.
So that's one thing that we absolutely believe in and absolutely practice is the exact location that we tell you it's going to go, it will be there, and we promise you that. So let's take some clinical studies at this point in time. I like to do clinical studies because it really drives home the point of how well patients do. And one thing that we've seen more and more of now is serial MRIs or follow-up MRIs, because now we're getting this data that's coming out here that's showing the benefit not only from the patient's outcome, but from a image outcome as well. So we have tangible data that we can wrap our hands around that says, look at the improvement in this particular situation. So this was a 59-year-old gentleman with chronic or refractory knee pain that just wouldn't go away. He had had everything done, ranging from cortisone shots and arthroscopic surgical intervention, and was still having chronic knee pain. So he opted actually for an adipose stem cell procedure where we did the mini liposuction and then re-injected his adipose stem cells back into the knee. And what he noticed was significant improvement of pain after about 6 months. His quality of life improved significantly. And at 12 months, his pain went down from an 8 to a 2 on a daily basis. He was able to run, walk comfortably, and basically do his daily activities of life very comfortably. And the reason why this happened is because this procedure stimulated the regeneration of a location of cartilage that was damaged. These can be often referred to as chondromalacia. And we did a follow-up MRI with this gentleman. So these tend not to show up, but they tend to drive the point home a little bit here. So what we noticed on the left-hand side, what we noticed in this particular MRI was a thickening of the articular cartilage on follow-up. And what I'll do here to drive this particular case home, I have another case with a much better images that we can go through. But what we're seeing here is a significant increase in density and thickness of the articular cartilage, which directly relates to this gentleman's improvement in pain and function.
I think another important aspect that you touched upon is the pain goes from an 8 to a 2, his activities of daily living increase tremendously.
Correct.
So
he's able to play with his grandkids.
Yeah, he's okay with 2 out of 10 as long as he's doing what he wants to do.
Absolutely. And what we saw here was this gentleman specifically, over the course, he ranked his pain starting at time point 0, which he ranked it as an 8. And you can see 1 week after this injection and this procedure, his pain had improved substantially already to down to a 3. And 1 year out, he was virtually pain-free. A moderate pain, and he ranked it at a 2-ish. But it would fluctuate a little bit, but what we noticed is a significant improvement in pain. And I'm going to show you a few more slides where this linear line down, which basically is pain improving day by day or month by month, is a real clear golden thread that runs through all of these studies.
True.
His KOOS score was just like his pain score. On KOOS scores, it's a little bit different. The higher the score, the better you do. And you can see that he began at a KOOS score of 44.6. And at the end of 1 year, his KOOS score was 96 to 92, depending upon the 6 month to 1 month, the 6 month to 1 year mark. But what you notice is this is a scale out of 0 to 100. He started at a 44, and he ended at a 92, 93 after 1 year.
So again, this is functionality.
This is functionality. KOOS scores are a measurement of functionality. How much does it hurt going up and down stairs? How much does it hurt squatting down to go to the restroom? How painful is it after 2 or 3 city blocks? These are the questions that we ask. Functionality, how are you doing in your normal daily life?
Right. So their disability is much less their functionality is much higher.
That is correct. So this was another study out of Rutgers University where we took 15 patients and they did KOOS scores as well. And we watched them over the course of 1 year. And again, what we're seeing is the same pattern of, a couple weeks after the procedure, patients are beginning to see improvement in pain and function. And what we did with this particular study, which followed 15 patients for 12 months, is we watched them gradually improve in their KOOS scores or their daily activities and their functionality. And we watched them improve substantially over the course of 1 year. 1 year was our endpoint with the study. But again, it's driving the point home. All these patients did significantly better after a few weeks out of the procedure and continued to improve for about a year. And we'll discuss about that endpoint of all these studies too in a little bit.
And it's important to mention that these are not our studies per se. It's just that we're following these studies that have been
And what I tried to do with this particular lecture was pull some really good data from major universities and something with really good imaging that we can wrap our fingers around and our hands around.
I think another important aspect to distinguish between spine and extremities is that I think in the spine, it's quite difficult to pinpoint where the pain is coming from. Like when you have the knee injury, you know where, like with the structures that are causing it, versus the spine, as we mentioned before, there's so many structures that it's the disc, the facet joints, the bone, the slippage of the vertebrae on top of each other. So I think, in my opinion, or in my experience, we tend to see a little bit better results in the extremities and the number of pain relief and the functionality compared to what we've seen in the low back.
That is a very fair statement. So the spine is much more multifactorial than extremities. That's a very fair statement. So this is an important thing to show. So what these are, these little squiggly lines are on your screen, on the left-hand side is what we call a control. We basically transplanted tenocytes or tendon cells and put them on a petri dish on the left-hand side. On the right-hand side, what we did was we took those little tenocytes, same amount, same quantity in both petri dishes, but we added mesenchymal stem cells to the right side and allowed them to grow. And so this drives the point home that when you add mesenchymal stem cells to any environment, whether it be a tendon or a cartilage, it stimulates the production of more and more cells. So the quantity of the tenocytes on the right-hand side of this picture shows a significant improvement in the amount and density of tendon cells when stem cells are added. So this really drives the point home, and I love this because all my patients like seeing this in every lecture because this is so easy to visualize. So on the left-hand side of our screen, what we're seeing here is a partial tear of the Achilles tendon, or this is actually a high-grade partial thickness tear of the Achilles tendon. And that's seen through that linear white line that angles down at an angle of about a 45 to 60 degrees mid fibers. And those mid fibers of the Achilles tendon are notoriously hard to heal because there's basically no blood flow to that area, and the Achilles tendon takes a tremendous amount of force on a day-to-day basis. What we did was this. We injected through ultrasound mesenchymal stem cells. In this particular procedure, it was adipose-derived, and we waited for about 6 months. This patient was extremely compliant, doing physical therapy, was immobilized for a few weeks, and did everything properly. 6 months later, the patient was doing beautifully. Pain-free, pain had reduced about 80 to 90%, very pleased with the results. And so a follow-up MRI was ordered, and there was absolutely no identifiable injuries on the follow-up MRI. The MRI basically looked like a clean, fresh, healthy tendon that nothing had happened to it before. And this really drives the point home of how effective these procedures could be. Because in conventional medicine, in this particular situation, your major options are surgical intervention.
Correct.
So, and no one's really happy at the end of the day with Achilles repairs.
I think you brought up a very good point about the patient being compliant.
Yes.
I think that's a very important point to discuss, since at the beginning, obviously, we want to be some bed rest, not bed rest, but some non-weight bearing, and depending on the joint and stuff. And then right after that, you have some recommendations for your patients.
And compliance is a huge issue in this. If you're non-compliant, you're not going to do well, I think, with any of these procedures.
Correct.
That's true. You've got to be compliant with these, because we're going to start the initial process of healing. We're going to transplant what needs to be in a certain place to start the healing process. So we're going to start it, but you really have to finish this. This isn't a magic wand where you're going to feel great. We're going to start this process, but ultimately it's on the patient to finish that process.
And I think you could see that in some of the studies we're going to go over, like some of the pain level changes and everything as well.
Oh yeah.
And as long as patients are compliant, which it's important.
So sticking with that tendon stem cell therapies, this is a rotator cuff. Now this is a little different. This is an ultrasound, so it's a little more difficult to interpret than an MRI for people that aren't used to looking at imaging medical modalities. But on the left-hand side of the screen, what we see here is an irregular contour to the rotator cuff tendon called the supraspinatus. The supraspinatus is the muscle that lifts your arm. And this is the injury in the rotator cuff, or this is the tendon in the rotator cuff that is most commonly injured. So about 6 months after the procedure was performed, the patient obviously was pain-free, otherwise we wouldn't have done this study, but the patient was pain-free, and a repeat follow-up ultrasound showed thickening of the rotator cuff tendon of the supraspinatus, a significant decrease in that contour or that partial tear of the tendon. And so really what that drives the point home is that there was significant repair of this tendon. And the patient clearly felt this because the patient did very well after this procedure on follow-ups. Now the shoulder, we look at the shoulder as a long-term fixation, especially if it's a partial tear of the rotator cuff, a degenerative labrum tear, or arthritis in the shoulder. We look at these as a long-term. And what we're seeing here, when we can quantify this data or take numbers to the data to how patients are doing, what we're really noticing here is 1 year out, patients have significant improvement in pain, and that's done through an ASES score. So what you see here is patients started out with functionalities of 35%, and this is a scale, 35%, and at the end of 1 year they were at 71% functionality. And so what we're seeing here is these continual graphs that patients are improving slowly through the course of 1 year with a gradual, slow, linear improvement. Basically, they improve on a stepwise progression over the course of a year.
And this points out to the fact that it does take some time for these cells to help with the repair mechanism and the regeneration.
Absolutely. So again, this was range of motion, and what we're seeing here on follow-ups with range of motion, when we're able to quantify or put numbers to this, is after about 2 to 3 months, we're starting to see significant range of motion improvement that holds and improves on the long term. And what we did this through both flexion and abduction, and these graphs reflect the degrees of how much you can do it. What you can see here is a significant improvement in range of motion and over the course of a year, and those benefits don't die off after a year. These studies stop at a year, but these benefits don't die off at a year. If you improve through the course of a year, what we like to say, both in my practice and your practice, is that's your new baseline.
Correct.
So you'll maintain that.
Exactly. So like in the spine, if you say you get 50 to 70% improvement, say you go from an 8 out of 10 to a 4 or a 3 out of 10, that becomes your new baseline. So your new level of pain is that 3 or 4 out of 10.
Correct.
So we can switch.
So
to
shall we
spine
switch
a little
over?
bit. Yeah. So we did mention a little bit earlier about the areas that we do treat. So I'll go over some of them in a little bit more detail. And for the low back, again, it's the area that people have the most problems with, followed by the neck, and then the mid back is the least. So again, going back to the pure axial, which means just the pain in your back, there's several opportunities for regenerative medicine. This includes the injection into the facet joints as well as the disc themselves. I'll go over a couple of studies. People that have degenerative disc disease, they're quite a bit of a good candidate for this. If you think about your discs, the discs are pretty much made of water. And as we age, the water content decreases and the discs begin to shrink. And this is why we lose height, because the discs have actually shrunk. When the discs shrink, they can crack, they can develop fissures, and then the central portion is where the cushion is, and that's called the nucleus pulposus, that can actually seep through these cracks and come out. And then that leads to what's called a bulging disc. And I'm sure a lot of people are familiar with the terminology there. You can think of a bulging disc like a jelly donut. You squeeze it, part of it comes out. Now, depending on the location of this bulging disc, it could be near a nerve, and then people complain of the pain down the leg, the quote-unquote sciatica that they complain about. It could be in the central portion of the canal, and that leads to what's called spinal stenosis, and that means narrowing of the spinal canal. Those are all have different symptoms, so we'll go over some of those. Another area that actually in the low back that's quite common is the sacroiliac joint that you kind of mentioned earlier. So anywhere from 20 to 30% of the pain could be coming from that area. And also people that have radicular symptoms like pain down the leg or down the arm, and that could also be due to a bulging disc or a combination of a bulging disc and a very large facet joint that we've discussed previously. Let me see if there's any other questions regarding that. So a little bit more about how we do things and what type of stem cells that we use, because I know there's a lot of questions out there about umbilical cord-derived stem cells. So what we mentioned earlier is that here at Cellaxys, we prefer to use the autologous, which is your own stem cells and your own PRP, your own blood to generate the PRP and everything. So we use either adipose in the extremities and then just bone marrow aspirate in your spine. There are third parties that do sell the umbilical cord. I think there's something more to it than just the mesenchymal stem cells. I think it's the whole quote-unquote soup that we're actually injecting back in, and then your body tries to heal itself. There's some exciting stuff that's on the horizon, the exosomes, the alpha-2 macroglobulins. Exosomes are pretty much what the stem cells excrete, so some of this we're looking into it as well. And there's a lot of opportunities there, but again, it's in infancy. There's a lot of research being done, but again, going back to what the research has been shown in the past 5 to 10 years is that the bone marrow aspirate for the spine has been the area that people use to
And with
utilize
dealing
the
with
most.
the spine too, it's best to have a very controlled environment, know what you're putting into that.
Absolutely.
And so in your practice, I know you really recommend utilizing your own body's natural ability, whatever that may come from.
And obviously some of those products, they test them just like any other, like blood transfusions and stuff, but I kind of prefer to inject something that belongs to yourself.
Correct. And we know where it's been, we've processed it, exactly.
Yeah. There's another question about how we obtain the bone marrow aspirate. So real quick, again, we mentioned it earlier in the webinar. We use a special needle to go into your hip joint area, the iliac crest, and that's where we extract the bone marrow, and then we spin it down, and then we combine it with the platelet-rich plasma and inject it into the specific areas, whether it be in the low back, mid back, or the neck, and the associated facet joints with it. This is one study that I wanted to mention. This was done in 2014. They had 26 patients. Now, if people are looking, they're saying, wow, 26 patients doesn't seem like a lot of patients. Unfortunately, a lot of studies in pain medicine are the number of patients, the sample sizes are not as large as in other specialties like cardiology when they have like 5,000 patients or something. So again, there's more studies that are being done and being published. So on this one, there was the 26 patients. As you can see, there was 13 patients had 1-level injection into the disc, and the other 13 had 2-level injections. 8 out of 20 improved 1 grade on the MRI.
And that's a big deal, though.
Correct. So this is what Dr. Auden was mentioning. So most of these studies, they actually follow the patients with serial MRI. So they get an MRI before the procedure, 6 months, and then 1 year after. And one great improvement, so they were talking about the hydration of the disc itself. So again, as I mentioned earlier, the discs are made of water, and the water actually shows that the disc is quite white. When it gets dark, it actually becomes dark.
And that water content creates the cushioning in the disc, isn't that correct?
Correct. It helps with that, because if the water content decreases and there's no more water in there, it's going to crack.
So your shock absorber is gone too, isn't it?
Exactly. And they showed about 58% improvement in their pain after 12 months, which is significant for a lot of people, and the activities of daily living has changed. So this is an MRI. Actually, you're cut up and down, and we're looking at the side view. The one on the left is the one before the procedure, and the one on the right is about a year afterwards. And the two arrows point at the L4, L5, and the bottom one is the L5S1 disc. You could see, compared to the other discs, which are quite white, the L4, L5, L5S1 are dark. And after 1 year of the stem cell injections, you could see there's some coloration, some hydration that's returned, and the discs are actually a little bit whiter. So that's kind of significant. There was no change in the height, but they did have change in the hydration of the disc in this study.
And again, that hydration, so this is analogous to this, that patient probably had more shock absorbing ability because of the hydration and regeneration of that disc.
Absolutely, and also that there was some repair of the cracks that were in there, and hopefully preventing any further bulging to occur.
So it's actually helping to repair the disc from the inside out.
Exactly.
Okay.
In this other study, this was done in 2017, 33 patients, so this is quite impressive. They followed them for 6 years.
Yeah, that's a long clinical study.
Yeah, which is like
medicine.
Unheard of, and then for the patients to stay in the study. So this is the one I kind of mentioned earlier, is that the bone marrow was actually taken from the patient. They were cultured in a petri dish, and the number was increased. So 20 had MRIs after the procedure, 85% had reduction in the size of the bulging disc, and there was a 23% decrease in the average size. So that's actually quite significant. So imagine if you have a bulging disc like what we discussed earlier, and the bulging disc is near a nerve, and if there's some reduction in the size of the bulging disc, that could actually take some pressure away from the nerve itself. And this is the problem that we talked about, the sciatica that's going down the leg.
So this would be analogous to for something up here as well in the cervical spine.
Correct. But this was the lumbar spine. Yeah, the lumbar spine. And then again, in the neck, in the cervical spine, we don't inject the disc, we inject the facet joints. And in this study, there was 50% improvement in pain and functionality, which is significant.
That's significant.
Again, we talked about 50 to 70% improvement overall in pain, and you have to take the whole patient into consideration. We're talking about reduction in pain and improvement of quality of life. So that's, to me, I think that the improvement in quality of life is more accurate and more important. So people can come in and they say they're still like 6 out of 10, but it's like, okay, I was able to sleep last night.
Right.
I'm playing with my kids or my grandkids, and I'm doing things that I haven't done in years.
Correct.
This is the MRI on the left. It actually shows the cross, you've been cut up and down, and on the right is actually a cross section of the MRI. The one on top is prior to the injection, the one on the bottom is afterwards, and there's been a slight decrease in the size of the bulging disc, and there's been a slight increase in the disc height itself in this study.
So the bulge is actually reabsorbed
by 0.5
and the disc is
millimeters.
actually increased in height.
Exactly. There was not much in the change in color in this one compared to the other study. That one, the disc is still dark, so there's no change in the hydration, but actually there was a change in the height and also the size of the bulging disc, which is significant.
Which is a very significant finding.
Yeah, and again, as we mentioned earlier, there's a lot of studies that are coming out. I would recommend people go on our website, and we have a list of the studies that are being published, and we kind of do sort of the synopsis on what the study was all about, I'm sure. And
we'll do the groundwork for you.
Yeah, and we also have a link to the study, so you don't. Yeah. So if you want to read the study itself, you can, and then we kind of boil it down to the study and what the outcomes were to make it easier for patients. So
are there any other questions that are out there? And here's where we kind of open this up to a few questions, and we'll try and squeeze out a couple little questions that I think are important, some random notes, and here's where I like to open this up at this point in time.
Before we do that, so because at the beginning of the webinar we talked about...
Oh yes, I'm sorry.
We
Yes.
talked about the people that will be watching this, and we want to make sure that this was worth your time as well. For the people that actually live in Las Vegas, if you go onto our website or call our phone number and you tell me you watched the webinar or you participated in the webinar, we will do a free consultation for you. We prefer you have all your images with you. When you call, we'll give you all the details. And for people that are actually not in the state of Nevada or can come to Las Vegas, we have a telemedicine portion to our clinic, and we could set that up. And in that sense, what we would do is when you call, we would arrange to get your images and also the reports or whichever we can. And then that way we can make the televisit much more productive.
Correct. So we can do a consultation online, basically.
Exactly.
It's kind of a FaceTime experience, basically, but it goes through some medical stuff. But it's a FaceTime experience. So if you want to talk to us individually, one-on-one, you have that opportunity as well.
So I know you guys are watching this webinar and hopefully trying to get some information out of it. Maybe you've had chronic pain for a very long time. Maybe you're contemplating surgery. Maybe you've already had surgery and you're thinking about a second or third, and you're very interested to see what else is out there. And we want to make sure that you guys get all the information and have every option available to you. And this is why the offer that we've mentioned earlier, that we want to see if you have a consultation with us, even if you're not in the same state, that we could do something sort of like a televisit, which is like a FaceTime. And after reviewing your images and discussing this with you, give you some options out there. Maybe surgery is the option, but let's see, maybe there's other options prior to that.
Correct, because about 80% of injuries and chronic pain typically is non-operative. And so for people that are listening at home, that you're probably looking for that, what else is out there? You know, what else viable to improve my pain, to improve my function and quality of life? This is what we're going to focus on today and really give you an educational background on the newer therapies that are available that have begun to come out in the last 10 to 15 years.
Yeah, and also maybe it's not you that's in pain. Maybe it's someone that you know, like a family member, and you're like actually trying to get some information for them. So this obviously extends to them as well, since you're participating in this webinar. So as we said, we were going to answer some questions, and some questions are coming up, and this one is asking about they've already had knee surgery and would they be a candidate for any type of regenerative medicine?
Oh, so that really tops on a good topic, is the post-surgical pain. And maybe I can refer that after I'm done answering that question. Maybe you can answer the spine issue as well after spine surgeries. So this is a case that I see quite frequently. Patients will come in with chronic post-surgical pain. It's debilitating in their life. They're not able to quite do what they want to do. They're close, but they're not able to. So post-surgical pain is something that I deal with on a regular basis in my practice. These regenerative techniques can be very effective for the correct patient. That being said, in this particular situation, imaging is absolutely important, whether it be a 3D reconstructed CT scan to make sure the hardware is in there properly, an MRI, X-rays, etc. And then after I've seen the images and that I see that the hardware is in place, properly placed, and there's no major complications, then you get into soft tissue injuries and soft tissue pain that didn't heal properly with surgical intervention. So oftentimes what I'll do with those patients is do a diagnostic injection with Marcaine and lidocaine. If their pain is substantially improved after that diagnostic injection, then they're a candidate for this stuff.
Correct.
But there is options available. I see this in my practice on a routine, regular basis, and there is solid improvement with the outcomes.
I think it's a very important point that we actually want to make sure that you're going to benefit from this procedure before going and spending the money. So the diagnostic injection is, I think it's very important for people to understand. It's not just, we're just doing this just for the heck of it. We're actually going to see if you're going to respond to this. And the same thing, that could be discussed with the spine. So the spine, it depends on what type of surgery you've had. So people can have anywhere from a laminectomy. Basically, they go in, they take a piece of bone out, and then they take a piece of disc out, which is the discectomy, all the way to a fusion. And the fusion, if they actually did go in and take your disc out, and then they put a spacer in. If they put a spacer in, then you're not going to be a candidate at that level because there's no more disc material left. But the level above and below, like what we discussed about the occurring in about 30% of the population after 10 years, they might be a candidate for that. And at that point, we can also do some diagnostic injections to make sure the patient gets some benefit from this before moving into the stem cell realm.
So there is options in post-back surgery or spine surgery with regenerative medicine then?
Absolutely. And I think the take-home message would be that you have to be evaluated. So I think it's very important. And again, I know we keep talking about this, but I can't emphasize enough at Cellaxys, it's so important that the patients are seen, they're examined, and we review the images and proceed from there.
Correct.
And again, we mentioned the offer earlier on. So if you guys are interested, please just follow the link on the webinar, and we'll be more than happy to provide you guys with some recommendations from us.
So here's an interesting question that I'm getting asked more and more of actually in the clinic these days is preventative injections for gentlemen that are in their 40s or 50s.
Or ladies.
Yeah, there you go. So I'm getting preventative questions. Yes, the answer is yes. I get asked this question frequently. It tends to be from ultra marathon runners or really high level athletes, professional athletes. And then, kind of the day-to-day people, the weekend warriors are starting to ask me about this is, can I do this as a preventative method? They had an MRI, it came up relatively normal. I'll use the knee because that's a very easy joint to talk about. But they noticed that there was a little bit of chondral fissuring or changes in the articular cartilage, and it was thinning, but it wasn't outstandingly impressive. But there was fine, subtle changes. And can they do this for preventative stuff to try to decrease the potential of arthritis down the road? The answer is yes. I have done these for preventative purposes where I've noticed mild changes in imaging MRIs. So the answer is
still
yes.
Need some images,
but you got to have images for preventative stuff.
To confirm this as well.
But the answer is yes. There is a gentle push recently I've noticed with doing this as a preventative measure, and the answer is yes, you are a candidate if you're interested in prevention.
And in the spine,
that's a different.
The spine is a different animal. That's I think one of the more important aspects of the imaging, at least with the spine, is like up to 30% of the population has changes on their MRI, but they don't have any symptoms. So the spine will probably stay away from the preventative stuff for now, and then see how, obviously the joints are quite important. And as you said, the weekend warriors and the athletes, the knees are the ones. That's
the first to go.
Everyone knows that something's going to happen eventually.
So before we get to our questions from the audience, let's just take a quick look at a few of our patients and their outcomes.
Hi, my name is Brian Plaster, and I'm 40 years old. I was born here in Las Vegas, Nevada, and just about a year and a half ago, a little over a year and a half ago, I was up here snowboarding, and I crashed into a tree. And it was one of the worst snowboarding accidents I could possibly imagine. I remember the injury happened back in March, and then I had the stem cells put in over the summer. I believe it was July, and by September I was good to run again, good to mountain bike again.
Until a few years ago, I'd been able to do just about any physical activity I'd undertake. As a child, I began running long distances, and I've always played competitive sports at a very high level. As you can imagine, after more than 50 years of doing this kind of activity and the stress and strain on muscles, everything hurt. It got to a point where I really couldn't even stand. So in December of 2017, I decided that I would have the stem cells and PRP done to both my knees, my right hip, and my right SI joint. The procedure itself was relatively painless. I was pain-free. I could then resume activities that I hadn't been able to do for a while and be active all day long. I've been able to play more sports be more involved, and actually I never ever dreamed I could get to that level again.
Combat sports weren't a possibility anymore. I mean, they were removed from my life. I couldn't work out, I couldn't box, I couldn't wrestle, I couldn't lift weights or run. Having something that you love to do and that you're extremely passionate about be removed from your life, it takes a toll. It takes a toll not just physically, but psychologically as well. And so I did some research in Las Vegas and I found Cellaxys and Dr. Matt Otten. The procedure was quick, it was relatively painless. I mean, I was in and out in an hour or two, and aside from some soreness for the next few days, it wasn't that painful. I'm almost back to 100% range of motion in my hip and shoulder. I'm almost 100% pain-free. I'm living the high quality of life that I love to lead, and it's all thanks to Dr. Matt Otten and Cellaxys.
Well, I think we could end it at that point.
I think you're right.
Yeah. Well, thank you for watching this webinar and participating, and especially the people that send us some questions. And for Dr. Otten and myself, we thank you, and we hope we see you at Cellaxys.
And we hope this has been educational for you.